I want to just quickly share with you the vision at SAMHSA. You know, SAMHSA really envisions itself as the public health agency that is responsible for behavioral health moving forward in this nation. And one of the things that we're trying to do across the country is to increase this conversation around the fact that behavioral health is essential to health. You know, whether you like it or don't like it, in this country we're now talking about reforming healthcare. There's something about our system in some ways that did not work. So what we're about is improving the healthcare experience. So when someone walks in your door, our goal is to say, hey, you're going to get the very best care you can. Not only are we going to improve the healthcare experience, but we're going to improve the healthcare outcomes. And in the same breath, we're going to reduce costs. You cannot do that in this country unless you address mental health and substance abuse as a health care issue. Now, let me tell you, folks in the healthcare world just didn't decide to wake up one day and wrap their arms around us and say, hey, you guys are the greatest thing since sliced bread. The reason they want us at the table is because our people cost them money. We are the high-cost utilizer. So the message we have is that it's essential to all health care discussions. Okay? Not only is it that, but prevention works. I heard we had some prevention folks here. We know that what you do based on evidence works. We know that treatment is effective. Now, I started my career as a, well, I started my career drinking and drugging. And by the grace of a very loving God, today, I am a person in long-term recovery. And I was sharing with someone earlier, my God has a great sense of humor. He takes a guy like me and provides him an opportunity to serve under 3 governors. The federal government even will hire him. You know? And I share that with you because the work that SAMHSA is about doing is making sure that people understand that people really do recover. Okay? We have a mission, which is to reduce the impact of mental illness and addiction on communities and tribes across the country. And the way we go about doing that is making sure that we have a voice and there's some leadership, and we look at funding and service capacities. We have a block grant that funds the states that requires that they do consultation with the tribes. And then we look at data and surveillance, and we have some regulatory responsibilities as a federal agency. The next slide. Part of the way we carry this message is, for the first time in the history of SAMHSA, we now have a regional presence in the Department of Health and Human Services. We've always been there, But you know how it is with mental illness and addiction. You're there, but you're not really there. And nobody really wants to deal with that issue. Well, today, SAMHSA is a part of all discussions with all of those other federal operating divisions. And in fact, they really want us there. This is a mugshot of all 10 of us across the country. And you all got stuck with Santa Claus. Next slide. SAMHSA has some priorities. Now, I really want you to hear this because when I talk about these priorities, it really is, as we talk about, it doesn't matter what the substance is. It doesn't matter what the mental health condition is. These are some priorities that are really going to start helping to guide us for the next 4 years. Now, these priorities that I'm going to talk to you about, you have an opportunity to influence them. Because right now, next slide, we're in the process of looking at strategic planning over the next 4 years. And part of that is we have a document that's available, and I have a link to the document, so you can go look at it and you can say, I don't like this. Oh, I like this, but I'd like to see more of this. Our tribe needs this, and you're doing that. It doesn't make sense to us. So I want to encourage you to go to the website that I'm going to give you. For the past 4 years, we've had 8 key strategic initiatives that have guided everything we do at SAMHSA. Next year, for the next 4 years, that will be, yeah, it's okay. The next 4 years, we're going to have 6. Some remain the same. For those of you who work in prevention, it will still be prevention. But if you go to this website, that link that I put up there, if you go to that, it will give you the goals and the objectives, some of the strategies, and if you say, hey, that's great, and I can assure you we're looking at depression, we're looking at suicide, we're looking at underage drinking, some of the same things that we've looked at, but if there are other issues that you think we should know about, tell us. That's what public comment means. I'm not telling you, at SAMHSA, my experience has been, we take that public comment and we've changed. The definition that we use for recovery in this country today didn't come from SAMHSA. It came from the general public saying, we like this, we don't like that, take that out, put this in. So I'm telling you, you have a chance to have a voice. Please use it. I want to point out just a couple things. Prevention remains the same. This one right here is extremely important. Number 2, healthcare and health systems integration. Extremely important. I would suggest to you that it might be the healthcare of the future. If in fact, behavioral health has its rightful place in healthcare, and we do today, we were moaning and groaning for years saying, you all don't understand, this isn't criminal, it's not weak will, it's healthcare. And they said, okay, it's healthcare. So come on to the table with us. You're a part of healthcare. Well, what that means is they don't always come in our specialty door. Did you know that? They come in somebody else's door. They come in the primary care door. Perfect illustration of what I'm talking about. In this country, older people who complete suicide, of that number, 17% of them saw their primary care doctor the same day that they completed suicide. So when I talk about integrated care, and SAMHSA says this is our strategic initiative, we see it as a matter of life and death. So we partner with HRSA, which is all primary care associations, the FQHCs, to get this message out that, hey, you gotta, you know, if they walk in your door, you gotta be prepared. Interestingly enough, HRSA just put out $54.6 million to expand behavioral health in their primary care clinic. You know how much went to the state of Oklahoma? 0. This is an issue. Trauma and justice, that remains the same that it's always been. Recovery support, the same strategic initiative. We're obviously not going to do the same things we did last time. We're looking at new ideas. And so if, in fact, you have ideas, let us know. Health information technology, still a major issue. It's a major issue around prescription drug abuse. How do we link all those systems so that we know how many doctors you're going to? Workforce. Y'all have enough people to do the job that you need to do today? This is a huge issue across this country. When you expand Medicaid and you look at Mental Health, Addiction Equity Act, and parity, which impacts over 62.5 million people, who's going to serve them? So, for the next 4 years, underneath this triangle is some of the internal strategies that SAMHSA will be using. So here they are. If you couldn't see that small print. Next slide. Part of what we're doing at SAMHSA is to think differently how we fund initiatives and to make sure that we're doing surveillance of problems and data. One of the major concerns is the data that we're able to have regarding Indian country. Because we can't address issues that we don't have data to support needs. So there's a whole process, and we don't really have time to get into it, but what I want you to hear is that as we think about funding initiatives in this country, it's extremely important that we look at evidence-based approaches or approaches that from a cultural standpoint have demonstrated effectiveness. And so with that, we ultimately hope to bring about change. And I'm going to turn it over to my colleague, and who will be...
Okay. We are doing something... I am turning on the mic. I don't have Michael's volume, so I will be trying to talk via distance or whatever electronic you can think of. My name is Helene Skinstad. I am Norwegian. And you will ask yourself, why are you here? What brings you to this country? Some of my tribal members says, because you always love turquoise. That's one of the reasons. The other reason is that I married an American. And I've lived here for 25 years, but I will never lose my accent. I'm a clinical psychologist, and I have specifically worked on issues around women and women with substance abuse issues and their children. And I started the first inpatient unit in Norway for women and children only before I came here. What brings me to this particular situation, I will get to as we go. We are going to go through all these, and specifically what I'm going to talk about would be drugs of abuse and 4 pillars of the ONDCP plan for how we deal at a community level with prescription drugs. And as you know, our clients have pain, so we're going to briefly go back and do that. And Mike and I will switch back and forth. Michael is directly employed by SAMHSA. I am a grantee and a director of the National American Indian Alaska Native ATTC. But I always have to remind you that this presentation is not representing the SAMHSA public view. I have folders on, I got rid of all my folders, but I will display tomorrow for those of you who don't get, I think there were about 5 people who didn't get it. And you will see some of our activities that we have. We also are going to ask you towards the end to evaluate this presentation. So, let's talk about what the ATTC looks like. Do you know who is the regional ATTC for your region? Okay. You are served by the South-Southwest ATTC. And that is Region 6. So from 2012, SAMHSA changed us all around completely. We were 14 centers in the old days. And then in 2012, we changed. And we were totally aligned with the regional director, regional HHS areas. That has, as Mike has said, increased the collaboration drastically. And since we are a national center, I communicate with a lot of the colleagues of Mike in all these regions. So I just came from Phoenix. I'm going back to my home state, which is, believe it or not, Iowa. And we are initiating something that you might find information about in your folder. We are initiating an all-American Indian Alaska Native Leadership Academy next week. And of course, being an agency that works with American Indians and Alaska Natives, we deal with your region, which is the 12 IHS regions, and we worked with different groups within that region. And the first year of my grant period, I called the year of listening. That doesn't mean I quit listening this year, but we traveled, I think I put on 100,000 miles last year, from Alaska to Florida to all zigzagging all over the country. Just to hear what are the real issues in your community. What do you want me to do? And please, again, you will see at the end of my presentation my contact information. If you have things you want us to do that I have overlooked or my center has overlooked, please either contact your regional ATTC, who is directed by Dr. Spence and Phil Lord, and he will connect me, or just pick up the phone or send me an email. We are available. Our mission is something that I want you to remember. One of the things that he talked about was workforce development. Our main goal is workforce development and provide technical assistance to tribal communities. And also to work and understand better what is going on in tribal communities, understand better what we now call culturally informed practices, best practices, evidence-based practices, but also experience-based practices. And there's one person on our advisory board from the state of Oklahoma, and that is Dr. Bigfoot. Anybody heard about Dr. Bigfoot? Yes. She is the one who phrased the concept of experience-based practices a long time ago. And what she did was to really look at what is indigenous knowledge. It is knowledge that you have gathered for hundreds and thousands of years. That is evidence-based. So we are working on trying to include those kinds of practices in what we disseminate. I've talked a little bit about this. We try to formally and informally listen very carefully, not just the first year, but the whole 5-year period. So we do ongoing assessment of needs, and we use a lot of technology. So if you look in your folder, we have 2 regular monthly webinars. One webinar series is focused mostly on substance abuse. Another one is what we call the behavioral health webinar series. And we use a lot of different presenters. Yesterday, if you didn't have the opportunity, didn't know about it, I suggest you go on YouTube or our webpage and listen to Dr. Clyde McCoy. He gave a presentation yesterday about the pride of all the sportsmanship that we have in American Indian communities, and how that should also be used as part of when we plan behavioral health initiatives. We need to look at the whole person, and he is an incredible speaker. We work with HRSA, we work with SAMHSA, and I want you to remember, I think it's coming up again, there is a grant period that is focused on how to develop infrastructure so you have spaces for interns that can be supported when they come to your organization. We tried to assist some tribal colleges and universities, and I think someone applied, but I'm not sure. I think we had to go all the way to Alaska to find infrastructure. But I know there are colleges in your area here, and I think it would be very important for you to align yourself with those academic organizations. So I think this is your turn. Okay, all right. We decided to put in here prescription that were, or drugs that are abused. And I'm sure I'm preaching to the choir. You know a lot about what I'm going to talk about, but I'm just going to quickly remind ourselves what it is we are thinking when we're thinking about prescription drug abuse. And one of the things that we've started thinking about is the definition of prescription medication used without the prescription. What do we mean by that? We may mean, and I'm sure we've all been sinners of this, I have back pain. I got some medication a year ago, and I'm thinking, I'm not going back to the doctor. If we are going to do this very stringently, this means that if I took that medication for my back pain without having consulted my physician, I may abuse it. So in other words, I should not be my own doctor. And the other one is when we use prescription medication for recreational reasons, and I know that our clients do. Lots of different kinds. What are the medications you know in your practice that are abused for recreational reasons that really are prescribed for something else? What do you hear? Pardon?
Lortab.
Okay.
Pain prescription.
Okay, pain prescription.
all psychotropic meds.
Yes, okay. So that also psychotropic medications are abused. Okay. Anybody else want to add to that?
Animal.
Yeah. A favorite?
The opioids and the benzos.
Okay.
To their
Okay. Anybody know about the abuse of barbiturates? I'm old enough to remember when they prescribed this, and it was a medication that really was abused. The barbiturates such as phenobarbital, meprobamate, all those things. Yes. Good old, strong medication that took care of too many things. And then, so misuse is also something we are talking about. The fact that we are handing out, we're sharing, and some of our children are going into grandma's medical cabinet and finding the real goodies. And that is also misuse of medication. And we know, as of a couple of years ago, that adolescents are really testing out most things in life. And in parents' medical cabinet, there are lots of things to look for. One instance I heard about that was quite interesting. If you are putting your house up for sale, that turns out when the realtor is going around looking at what you show in your house, someone may have to go to the restroom and whoops, some things disappears out of the medical cabinet. So we've found very many different ways of getting a hold of this. So let's just, you told me something about the prescription drugs that are abused. I'll just remind us of what this means. They look like M&Ms, don't they?
Skittles.
Yeah, Skittles, right. We've talked about pain control and the opiates. We know that that is quite often and easily abused. Anxiety and anxiety disorder drugs, the benzodiazepines. And every time I hear we have discovered the wonder drug that is going to take care of most things in life, the Valiums, we had that in the 70s. We know that this may not be what it is deemed to be. And then, of course, ADHD medication, we know, has a tendency to be abused. And what are the addiction potentials? One of the things that are so dangerous with these painkillers and benzodiazepines is the very fast increase of tolerance. That means that for the same effect, you're going to have to take more. And it develops very quickly. What I also want to remind you, some of the sleep aid may have the same issue. That suddenly one of your clients will say, well, I wake up now every night at 2 o'clock and I need to take another one. That's an example of tolerance. And the effect it has on the sleep that is not good in the long run. Okay, we'll talk more about the fact that yes, our clients have pain and they need to be medicated for that. Here are the opiates, and I know you have heard a lot of these: Vicodin, oxycodone, codeine. And one of the things that I have worked with the College of Dentistry is that when you have your wisdom tooth extracted, our dentists don't want you to feel pain, and bless their heart, but they don't need to prescribe 30 of codeine and then say, whenever you need more, just call.
It's a good dentist.
It's a very good deal, as you say, but it's one of those things that isn't medically advisable because you can easily have a problem not taking more if you feel that this is really helping you. And we know something about the withdrawal, the opiate withdrawal that is used for pain, very often in withdrawal or in intoxication, gets people to be very drowsy, to be confused. Very often people get nauseated and depressed, respiration. When is the worst time for vulnerability when it comes to opiate overdose? Let me give you a cue.
Sleep.
Pardon?
Nighttime, sleep.
That's true too, because nobody will see you. But if you shoot up in a different location than you've shot up before, that's very dangerous. Secondly, if you have been in recovery, if you have not used for a while, our clients do not remember that when you stop taking, you've not taken for a month, for 2 months, 3 months, your tolerance is down considerably compared to what it was when you were actively using. So a very dangerous spot is someone who relapses into IV use of opiates. Benzodiazepines, in my clinical practice, there was one guy who took the prize. He consumed 800 milligrams of Valium a day. How he was walking straight or standing up still, I don't know. We spent a lot of time withdrawing him, but it's not a very dangerous withdrawal. It can be, but of course him, we couldn't do any cold turkey. But with the barbiturates, as we will talk about later, that is not a medication that any of our patients should try to withdraw from without medical assistance. They are nasty things. Okay. Stimulants. How many of your clients have started abusing stimulants after they have been on medication for ADHD? That can happen. And another thing is diversion, that oftentimes it's diverted that, you know, you take a little bit and you realize this is worth a lot on the black market, and you will see that clients sell this. So stimulants can be addictive. Ritalin, of course, is what we have used. Withdrawal can be very unpleasant. It's not life-threatening. However, what we see, and I'm sure you've seen in your communities, is the increase in aggression when people start using too much methamphetamine. When the community is infested with methamphetamine, you see an increase in psychosis and also aggression. So, are you going now, Mike? Just start talking and I will get this.
I think what we want to try to do now is kind of give you a national perspective. I really appreciate the fact that Ann kind of set the stage with the types of drugs that fall into that category of abuse. But what I want us to be able to see is, from a national perspective, what does this look like? Because we hear a lot about prescription drug abuse. And not only, you know, it's always, and I used to say this when I worked at the state level or at the community level, well, that's great, that's what's happening all over the country, but what's happening here? And so we'll be looking at what's happening here in Oklahoma. and we're going to take a little picture of what's happening, at least as we gather data from SAMHSA among the tribes themselves. Okay? But again, it's national data. I don't have the data for the Oklahoma tribes. Okay? So we're going to look at these emerging patterns, and next slide. Over this time period, Ann's already indicated she's going to be talking about some of the solutions that came out of the Office of the National Drug Control Policy at the White House, and those 4 pillars. We're going to talk about some tribal prescription drug abuse programs and initiatives that Ann's going to share with you, and then I want to talk with you in the latter part of the day about what I think is an opportunity to gather around a community to develop a tribal action plan. And SAMHSA can be involved in providing that technical assistance. When we look at overdose deaths in the country, it's important to note that we're talking about over 38,000 individuals that died from drug overdoses. That's in 2010. That's the most recent data that we have. And when you look at that national rate, it's 12.3 persons per 100,000. Look what it is in Oklahoma. In case you can't see it, it's 19.4 per 100,000.
What number are we?
You're actually ranked number 5 in the nation. Not on a good list.
Yeah.
You know, it's nice to be up there high on good things. This is not a good thing. Okay? So when we talk about prescription drug use or misuse in this country, we know that just a little over 22 million, approximately, persons initiate non-medical pain relief since 2002. Okay? So that's in the past 10 years. That's a little more than 1 in 22, or 4.6, reported misuse or abuse of prescription pain relievers. About 4.5% of the world's population, that's what we represent in this country, 4.5% of the world population, yet we consume 99% of the world's hydrocodone. So what's the message?
Cut off the hydrocodone.
Yeah.
Yeah, but the message is, in this country, you got a problem, take a pill. Do you hear what we just looked at? 4.5% of the world's population consumes 99%. Emergency room visits, obviously up from 5,212 to over 15,000, and about 1/5 of those involved illicit substances, some alcohol, but nearly tripled just for stimulant use, ADHD. Now, trust me, that wasn't because they were diagnosed with ADHD. It might be that their child was put on ADHD, and mom decided that if I take some of this, I can leave this house in a hurry. And she ends up in the emergency room.
Sorry.
That's okay.
Do you want
I do want you to see that benzodiazepines, you know, those anti-anxiety drugs that Ann just shared with you. Look at what the pain relief abuse increase is there. Over 569%. So you begin to see the picture. This is a problem. Okay? Let's look at Oklahoma on these maps. The map up in the far left corner is for opioid pain relievers. And this map actually reflects the number of individuals per 100 that have had prescription opioid pain relievers prescribed to them. And if you'll notice up there, you probably can't see the numbers, but Oklahoma is in the highest category of 96.6 up to 142.9 per 100. So if you're at 142 scripts for 100 people, then you got more scripts than you got people, right?
It's doubling up.
Make sense? Okay. So, you know what Oklahoma's is?
What's that?
127.8 scripts for every 100 people.
We're on the rise.
Huh?
We're on the rise.
Yeah, well, you rank number 5 in the nation.
1 for 4.
Now, the reason I'm sharing this with you is there is a direct correlation to the number of scripts written and the abuse. Obviously, if you got more scripts than you got people, something's going to get diverted. Or you're addicted. Okay? Talk about benzodiazepines. You're in the category, you drop down a little bit, 37.3 to 45.5. But you know where you rank there in that category? 44.5.
Nice. Right at the level.
Number 16 in the nation. Wrong answer. When we look at long-acting, extended-release opioid pain relievers. Okay? So it's a different type of pain reliever. Time release. What kind of medication do you know?
Fentanyl.
Huh?
Fentanyl.
Okay. Usually the OxyContins are time release. You know, that's why they cautioned people initially. They were crushing them or chewing them, and you know, you get all of the time release at once. Now, in that category, you are in 11.3 to 14 per 100. You're actually 12.8, which makes you number 20 in the nation. And then, last but not least, when we look at high-dose opioid pain relievers, you're again at the top of the ladder, and that's between 5.4 and 8.8. You are at 6, which makes you number 8 in the nation. So you understand why this topic is important. I don't know if in your practices you're seeing this. Are you? Are you seeing this? Any primary care practitioners in here? Any health centers? I heard hospitals, in here. Are you guys seeing this in hospitals? Now, what's the solution to this? From a doctor's standpoint, what's the solution? What's the solution? Huh? Yeah. What do they do? When they find out about this, what do they do?
That'll cut off the scripts, right?
Oh, yeah.
I think so.
Yeah, that's it. We shut you down.
So how do you?
So then what happens?
How do you control?
They knock on your door, and what? What do you see?
Oh, hurt people.
Yeah, they're hurting.
Yeah.
Acute withdrawal.
Yeah.
Or they jump to something else.
Yeah, acute withdrawal. In fact, some of what we're experiencing, this is more so on the East Coast, and I don't know about where we are here in Oklahoma. But a lot of what happens is individuals, they can't just stop. The nature of the substance will not allow them to stop. So they've got to find, medicine cabinet, they got to find another source. So many folks are going to the street and either buying it off the street being diverted or switching to methadone or heroin. And heroin's cheaper than their script.
It's true.
And guess what happens then? Overdose. So a huge issue. I want to look some at the opiate-related admissions to substance use treatment centers, rates per 100,000. These are for 12 and up, and it's not including heroin. And I just wanted you to see that those rates for opiates were 400% higher in 2010 than they were in 2000. Rates increased in every year since 2000. Yes.
Question. How do you limit the medical field from prescribing that kind of stuff? Because I know my mom had I can't remember if it was cancer or whatever it was, but she had like 1,000 Lortabs. There's no reason my mom would need 1,000 Lortabs. You know what I mean? But that was the script.
Well, Ann will be talking about one of the pillars
Yes.
that the Office of the National Drug Control Policy has suggested as an evidence-based practice that we put in place. So she's going to, if we don't answer that,
gonna get it.
she's
All right.
got all the answers.
No, no.
They just let me up here to
Women usually do have
fill
all
the
the
space.
answers. So
No, we don't.
Yeah, you got that right.
Yes, absolutely. You
Okay.
want to, okay.
Yeah. Now, when it comes to the American Indian and Alaskan Native non-medical use of prescription type pharmaceuticals, by age group, I wanted to just share with you the percentages. And this is for the last 2010 through 2011. And if you'll notice, in the 12 to 17 group, in 2010, there was 11.5%. That's jumped to 14.3. Now, that's for past year use. When you go to past month use, it went from 3.4 to 7.6. So the numbers are going, the markers are going the wrong way. 18 to 25 group, slight increase. Interesting. For past month use, as reported in that age group, it went down. 26 and older, increase, increase. Next slide. Now, this is non-use of pain relievers for those same age groups past year. Up, 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 not up. 18 to 25 past year, slight decrease. Past month, decrease in that age group. Decrease from 2010 in the 26 and older, and a slight increase in past month. And that's from our 2011 survey. Next slide. So, some of the reasons that are reported for not seeking treatment. You know, in this country, we talk about the fact that only 11% of the identified need for substance abuse treatment is being met. So many folks don't knock on our doors, okay? Or they knock on the door and we don't have room, okay? So one of the biggest reason was no health coverage and they could not afford cost. Did I hear we had a navigator in here? Yeah, by navigator, you're actually helping people to get enrolled? No, not that kind of navigator. I was just curious, because there were navigators that specifically were looking at how they could help communities find out about being eligible under the marketplace. So we're not either they report they're not ready to stop using. When they get as bad as so-and-so that died yesterday, then they'll quit. They had health coverage, but they did not cover treatment for substance abuse. Now, that's an issue that parity needs to help with.
Yeah.
They might have neglected, they might have a negative effect from their job. Todd and I were talking earlier, what happens a lot of times with this medication, as opposed to marijuana or some other illicit substance, is you can take all the Oxycontin you can stand
You got a
as long as
script.
it gets work.
And have a script.
Yeah, and have a script. You know? Try taking a drink on the job. Both legal. They might have this negative effect on their job. They do not know where to go for treatment. There's no transportation or it's inconvenient. This happens a lot in rural communities and frontier. There just aren't the resources, and there's no way to get to the resources. And I suspect that some of you experience it. And then, you know, the whole issue that might cause some neighbors or community to have a negative opinion. What they don't know is the neighbors already know. You know? But some, in their mind, they think they've kept this a big secret, right?
Yep.
Yes.
Okay, and then they just didn't have time. Next slide. So when we talk about these patterns of prescription drug abuse, it's important for those of you who are doing this work to remember that, you know, we've got 65% of all of these folks that are taking prescription drug abuse or abusing prescription drugs are low risk, you know, and 30% of them are, you can go ahead and advance the slides. So this is kind of what they look like when we identify them. If you just keep advancing, yeah. Yeah, again. Okay.
Perfect.
This is elegant.
Yeah, well, somebody else did it. I just...
Do I have to do one more?
No, we're good.
Okay.
We're good. So what I wanted us to see is that among this category of prescription drug use, there are many of the folks that are at low risk. So not everybody that takes a prescription is misusing it, okay? But then you have this harmful and hazardous use, which is kind of that pattern that begins to say, well, you know, it says 2 for every 6 hours, but I don't think they knew what they're talking about there.
And then they wash it down with a beer.
Yeah, I need 4 more of these, and maybe I could get some of, you know, my grandmother's.
Yeah.
So there's in that hazardous category, and then obviously abuse and dependency. But where we really need to start thinking about, and I'm glad that we've got folks in here who work in the area of prevention, because we really need to start thinking about in those primary care settings, in those health centers, doing those screenings and making those interventions. And we'll talk more about that in just a few moments.
I just made this thing.
Okay. Do you know when we are to break, guys?
What's your agenda say?
Are we supposed to break now, or I thought 2:30? 2:45. Okay, all right. I'm going to talk about something that somebody really called community-based participatory program or research. I didn't tell you how I got into this area with working with American Indians. I had a Center of Excellence in 1998 with a dear friend and colleague, Dr. Dwayne Mackey, as my coordinator and director of American Indian Initiatives. And he started teaching me this way of working with the tribal communities. And I want you to think about how this model is when I start going into detail on the ONDCP 4-pillar model. First of all, it's very important that you, as a community member, think about what is really the issue. What do you want to change? I'll give you an example. In Iowa, there was a little community that was involved in a research project in my department. And we did some checking on weight. 75% of the community members were overweight, and 50% were morbidly obese. So, you know, this was an issue that the researchers wanted to apply for a grant. Community didn't want it. Their issue was not obesity at that specific moment. It was that they had lost 2 high school students to binge drinking and fatalities in a traffic accident. That's an example of the community needs to tell us, and you, what they want to change. You can hire consultants, or you can also do it yourself with support from others. But there's one thing I want to really highlight here. If you listen to what Michael said, he was referring to data on a national level for prescription drug abuse. He was not referring to your community. And oftentimes, that is a sensitive issue in Indian country. I know you don't want to be evaluated and counted head by somebody outside, so you should do it yourself. Why is that important, especially in this? Because when you start doing systematic intervention on a community, you're going to see change, and you want to present that to your elder and to your community member. So, one thing I want to also say, we identify usually the problem, but that's not where the solutions are. The solutions are, where is the community's strength and assets? I don't know if you remember, a year ago, a Wisconsin tribe declared a state of emergency because of artificial cannabinoids, and connected with Michael's colleague Jeff Cody in Chicago. He sent out an email the day afterwards, and within 24 hours, I was very amazed. We had sent him whatever materials he needed so he could share with the tribal community. The tribal community got together and, based on what we had provided, started planning an interaction. It was very impressive. So the strength of that community was that they all agreed, this is something we want to do something with, and we're going to do it ourselves with support. And what I also want to really stress is the facilitation of a discussion and the action that you take as a community. Need to use media, and I actually remember when the radios looked like this. Do you, Mike? I do. And we don't work on radios anymore. We work on social media, we work on tweets, we work on all those specific strategies, and oh boy do they work. But of course, unfortunately, a lot of times there are bad things in all this too, so you are battling how can you take control over the message. But it is possible. In tribal communities that I have seen working on this, they have really worked and used their art. They've used their resources in their communities, their traditions, and that in and of itself has been very, very important. Shared concerns, way of life. How can we do this in a way that is culturally informed and culturally appropriate? Very important. I think this is also very important. I want to share with you a very touching story where I am in a training and we have several national trainees who are going to work for us. And one of my staff members listening, and one of our colleagues started sharing some issues. And the issues were very emotional to her. So even though this was a professional training, obviously she needed to share. So after that interaction and after all the concerns she expressed, my dear friend and colleague went up to her and said to her, "Do you sing from your tribal community?" She got a little nervous. She thought we were going to expect her to be singing in the audience. He said, no, I don't feel comfortable with this. So he said, but I can do it. I will sing a forgiveness song for you. And we all got out of our chairs. How do I pronounce it? You know what I mean. We stood up. And he used the table. He was a drummer. And he used the table as the drum, and he sang forgiveness. And all those very strong strategies and initiatives are what I think the communities can carry. So we all thought, yes, there are things in most communities that really are very, very important to keep. I think we have talked about this. So now, if you think about what I have talked about, I'm going to introduce to you the 4 pillars of an action plan that ONDCP developed and we took. Let me see, yeah, okay. I will start with 1. And this came about, again, in Region 5, which was part of where I used to work. I used to be a regional agency director. And Michael's colleague, Dr. Cody, and my counterpart in Chicago, and our center covering the Aberdeen area and some of the other states around, got together and found tribal members who could speak to all the different levels of this action plan. And we developed a proceedings document that you can see on our webpage. And I very much recommend doing this because what we did afterwards was to create a learning collaborative of all the tribal communities engaged in this process, and they started sharing. So I will go through the pillar and then also show you the different programs that you can access on our webpage. So the first one is education, 2nd, monitoring, 3rd, disposal, and then of course enforcement. And if we look at the education pillar, who do we need to educate when we are looking at a community-based participatory programming? A lot of our community members don't understand addiction. That's not because they don't want to, but they haven't heard, they haven't been exposed to it. So it's very important to expose the community members of different sides of what happens when people use substances, from what happens to the unborn child, to what happens to a community when we, in a public health sense, says it's a drug-infested community. What do the community look like?
Anadarko.
Pardon?
Anadarko is the town I'm from.
Yes, but the main thing is reduction in community involvement, and it's very important that we don't have a reduction in community involvement. Increasing crime. Who should be educated? And if you think about the peer support model, if you think about the importance of elders in your community, teachers, parents, children, doctors, and you know, we very often have a tendency to stigmatize and sort of scapegoat the physician or whoever prescribed. This is a community effort. The physician may not know that this client is abusing. So the community needs to rally around this concept and be willing to use your eyes and ears, both for the individual but also for the community level. There is one method that I think is very important to think about here, and that's what we call SBIRT. I'm sure you've heard about it many times. It's the screening, brief intervention, and referral. And it is a method that is a reinvention of the wheel. This was discovered in 1977, that if we could get our risky drinkers, risky abusers, to really get an intervention in the form of somebody talking to them about, you have a problem because you're using so and so much more than what the general average is, and if you don't reduce, you may have a problem down the line. So that then turned into SBIRT, and we have an ATTC, national ATTC, that focuses only on SBIRT. And we have tribal programs in New Mexico and other places in Alaska that have taken this and made it their own. So there are models to use SBIRT. And what we also talk about in public health sense is that when people come into the emergency room, have had an overdose, something bad happened, an accident, it's in public health sense a teachable moment. And it's a teachable moment that we should not lose. And that goes for the doctor's office too. And especially because primary care and behavioral health will be integrated and need to go hand in hand. I want you also to think about NIDA, NIAAA, and CDC have several different parts of their webpage focused on this completely. But the education also needs to include something of what Michael was talking about. Prevention work, treatment is effective, and people recover. I gave a presentation 2 days ago and one last week, and I was thinking, I think we have not stressed enough that our substance abuse is a chronic disease. We cannot just dry them up as we used to do and throw them out. We have to make sure that there are a lot of programs involved in this. And also that this is a relapsing disease and reduce the tendency to stigmatizing the clients. And we want our clients to know about all these. We also want them to know about pharmacological treatment if that is accessible for them. So what I'm wondering about, are we close to the... I'm wondering if we should stop. I will go through the next 3 after our 10 minutes break, and we'll be back. And I hope to see you all. And what I want to also say, if you are leaving early, please help me complete the GIPRA forms in your folder. And for those of you who didn't get folder I'm going to display later on today, and I'm going to have lots of material on that table.
Form for her evaluation.
Yes.
That's
Let me
that's her
show you.
That's her personal evaluation. Then they have the evaluation that's for the.
So these are the two. So there are two because your conference wants you to complete this, and we are wanting you to complete ours.
Where's your mic?
I'll finish. I'll do it.
Oh, I hope so. I hope so.
Hey, Rick's here. Okay. It's coming. You know what it is?
Where they refer to monitoring of how much prescription drug abuse has been made. Some states do not, but the majority of the states have. So I'm thinking that what would be important before you implement something like this is to check out what is the state law in Oklahoma. Who has access to this database? And you see there are several agencies here: providers, prevention specialists, law enforcement. However, at the bottom here, two agencies in the federal government do not have access to this, and that is the VA and the Department of Defense. But Indian Health Service do. So it depends on whether you are a direct services tribe or get your funding from IHS. They have different ways of tracking this. And you can access this if your agency have the opportunity to access this. So this is one way of helping you as a provider is abusing. We all know that sometimes it's difficult for our clients to remember, or they feel stigmatized enough so they don't want to remember, and you can track that a little bit by making sure you have access to that database. And this is also the importance of health records. Health records, if you have that capability in your organization, you will be able to follow this much more than if you don't. And we talked about the relapsing disease that this is, and knowing that people do relapse, but it doesn't necessarily mean that they are back to the very abusive and destructive way of using. But it's also a way of tracking, and I know Mike talked about 95% of our clients don't think they need treatment. It's something we actually need to. If you have diabetes, you know you need treatment. If you have a substance abuse problem, you have also a chronic disease, and you should know that you need treatment. When we look at the methadone clinics, they are monitored very carefully. Are there any methadone clinics that you work with in your community? Is that not an approach that you are used to? I have heard a lot of tribal communities tell me they don't believe in this. And I think part of the reason why that is the case is because there isn't an infrastructure.
On the monitoring system that you
Yes.
house, if I don't work for a healthcare provider, how do I find out if that's being used, or is it being used in Oklahoma anymore?
Can you answer that? The monitoring, you know that the state laws are...
Yeah, my understanding is that Oklahoma has a prescription monitoring program. In fact, I thought I just read an article the other day where states are faced with. And there have been a couple states, I know New York is one, where they mandated reporting by physicians and pharmacists. And sometimes absent that mandating, there have been issues. So, I mean, it leaves a gap in, if not everybody's reporting, then if you're actually monitoring what the traffic looks like in terms of prescribing or an individual going from one doctor to another. Someone was sharing with me in the hall that there were a couple clinics about 45 miles away, and neither of the clinics communicated with each other, but individuals were getting prescriptions in both places. So that's the purpose of the prescription drug monitoring program, is to eliminate that, quote, doctor shopping. But if it's not mandated, then what do you have?
Who enforces that?
Who enforces it?
Well, it's actually, it depends. Some states do it differently. The state that I worked in, the pharmacy board introduced the legislation, and they monitored it in conjunction with law enforcement. But there again, this is not to throw this healthcare issue back in the criminal justice system. If in fact prescription drug monitoring programs really work, they work as a point of intervention, not where we're going to lock you up and throw away the key. So it is an opportunity in those partnerships to help our folks on the criminal justice side. A lot of this has been done via drug courts, is to help that criminal justice system understand that treatment is what's effective. And I think we know that. It's just getting past that, especially with monitoring.
Yes, go ahead.
And this is, I guess, for anyone from IHS. Does IHS use that system, or is IHS required of all of them? Does anybody know?
I can tell you Cherokee Nation keeps a monitor on their archives
Yeah.
to the electronics.
So
It varies from tribe to tribe
Yeah,
too,
very.
and I knew that. But for those who may not have that within their tribal community, you might want to go and look within IHS about that. And I co-presented with Susan Carroll, who's the medical director of IHS headquarters. And there's very clearly a very extensive approach to monitoring within IHS. Was that answer to your question? Okay. So let's talk about disposal. Remember we talked about the frequency with which we forget that we have medications in our medical cabinet. It's human nature. And we need to really look at the danger of having a lot of things in our medical cabinets, both because it's not a very safe place, but also because people have access. And the theft and diversion, and also the older we get, the more tendencies we will have to mix up medications. Forget that we've taken it and maybe we should take one more for good measures, or to make sure we are following doctor's advice. So this is also, but this one is very important. The medical cabinets are very often at a height for kids, and that is a temptation. Because remember, they are colorful, they look like M&Ms, they taste a little different, but kids can get into this. So this is one of the reasons why disposal is very important. yourself these questions. Do you have a safe place for where your medication is? Do you know everybody coming into your house? Do you trust everybody coming into your house? Is your medical cabinet locked? Questions we all need to ask ourselves. And when it comes to disposal, do not flash it down the toilet. Think about the environment in this. We should look at, for instance, the National Prescription Drug Take Back, which is very often in many communities. I have just referred to one date here. In Iowa City, we have 2-3 dates.
It's actually the 27th this year. That's
The 20, is it? Okay, so I should have written 27th, 2014. Thank you. But people do it any other way too. Some community does it through the hazardous waste program. In Iowa City, we do it together when we hand in leftover paint. You know, those kinds of things. But that you have the opportunity within your community. Yep.
I was telling Mr. Duffy that in Oklahoma, the Bureau of Narcotics provides a drop box in every county sheriff's department in Oklahoma. And so that is free and it's open 24/7 to the community for people to drop off. They don't have to walk, you know, it's anonymous. They can just, you know, put it in a bag, put it in the box, and they will come pick it up and dispose of it properly.
Did you all know about this? Great. Oklahoma has a very good system. What, is it open all the time? Great. So, the last pillar is enforcement. And enforcement is oftentimes one of the pillars that people grab first and don't continue with the others. Enforcement is very, very important, but it should always be in combination with something else. I want you to look at this statistics. What do you think? 325% increase in thefts from pharmacies and hospitals. That's huge. It doesn't mean that our client broke into the offices all the time. No, it means, unfortunately, that some of our colleagues are tempted and diverting the medication. So what is important from a law enforcement perspective is to monitor closely what happened to the medications that we have in our doctor's offices, etc. And also, of course, pharmacists. So here is what was identified in this specific symposium we had 2 years ago. All these agencies need to really collaborate. And of course, when we look down at long-term and home care, of course, that is a set of agencies where we know it's very tempting because our elderly clients and our sick clients are in need of a lot of painkillers, and a lot of diversion happens from long-term care facilities. What I also want to say, and that is, I don't want to stigmatize ourselves, but many healthcare professionals are specifically vulnerable. And we often refer to this as, what is the distance between you and access to the medical cabinet? So as a psychologist, I may not have very much access. A nurse will, a physician, pharmacist, and there's a couple, a dentist, but the anesthesiologist is the professional group that has the highest percentage through years of use of diversion. That doesn't mean they haven't worked very much on this, but it still is the case. And I don't know about Oklahoma, but I know in several states I've worked, the pharmacy organization have developed a lot of very good monitoring and enforcing programs for their pharmacists. And the main thing is, as you say also, it's not our goal to throw people in prison, but it is our goal to make sure that people don't divert this medication, but also don't feel tempted too much and don't jeopardize the treatment of the clients in the process of this. So we don't want to stigmatize anybody, but healthcare professionals are vulnerable. Here are parts of our webpage. And this is where we have the whole prescription drug abuse document that you can download. I don't think we have any more paper versions, but this is also where we added a lot of the follow-up presentations from tribal communities. And this is what I'm now going to quickly go through. Remember I talked that this was during the time we worked with Wisconsin, this is Indiana, and Michigan, Minnesota. And after this symposium, tribal communities went back home and started talking, how can we do this? And they all did it differently. Here is a community that described an overview of policies and procedures. What did they have in place that they needed to reinvent or put back into motion? And they did that and could show a lot of improvement, because sometimes policies sort of get dormant, and this community in Indiana did that, and then they started really working on dispensing, creating a system that worked in that tribal community. This is a community in Michigan, and they approached this problem in a different way. They looked at the laws to start with, and then they wanted to work with drug courts. And how many of your communities have wellness courts? Okay. Can you say something about how your wellness court is organized?
It's
I think you need a mic.
I don't, if I talk like I normally do.
Yes.
It's a combination of the court system, legal supervision, and treatment. It's a year-long program, 4 different phases. Corrections, alternatives to incarceration program, and it was a big. She organized the program. It was a big success. Still is.
And here you see. Let me see if I can get this up. They also used 4 phases in this for each one of the clients who were engaged in the wellness court. And they put different timelines on them and really monitored the whole thing, and people had to come back and appear in court. Here is something in White Earth, Minnesota. They were very concerned about chronic pain management and how to really train their providers. Because, as you know, people have pain. And I want you to realize that we have in CSAT a tip 54 that is called Managing Chronic Pain in Adults with or in Recovery from Substance Use Disorders. It's a very, very well worth consensus document, and I have a couple, but you know, it's very easily downloadable from the internet. And they also was concerned about the disposal. They put enforcement in place, and they really worked with IHS and their tribal community to really follow up and monitoring the development of prescription drugs. And they were very successful. And again, they evaluated and reevaluated the program on a later stage and continue. I think they continue with this program. Ho-Chunk Nation looked at, remember we talked about substance abuse being a chronic disease, and they really focused on the chronicity and wanted to look at how can we make our clients well. So again, the wellness, the holistic approach to how to assist one of their trouble members in getting better, or many. And again, the interdisciplinary patient care model. And this one was a challenge. And it's a challenge for all of us. What kind of expectations do we have for our clients? Are we going to be realistic about it, or are we thinking that everybody is going to recover quickly and they're never going to use again? That was part of what they looked at from their trauma community's perspective. What is White Earth and Red Lake looking at now? They're looking at, and we're working very much with them on this issue, and that is prescription drug abuse in pregnant women. And we've just started, so we're using the same model, community-based participatory programming, and leaving a lot of this to the tribes, but also encouraging them to do the assessment, evaluation, and follow-ups. Oneida really looked at what kind of resources do we have? Do we need to align ourselves with external partners? And they decided to do that. And they had partnerships organizations, met frequently, followed up, monitored what was going on. They also looked for outreach, how to reach out to their community members when they started having suspicions about how this was really going. And looking at what do the providers use? How do they deal with chronic pain? How do they deal with people who come into treatment with a substance use disorder, with use of prescription drug? So in summary, what we saw was we had a very big and successful summit with introductions of this 4-pillar model. And then we engaged all the communities that wanted to work with us in a learning collaborative, and they presented their results and looked at how they could track the reduction of prescription drug. So it created quite a lot of pride, and I was very impressed with the communities. The key was tribal leadership and elders, and a comprehensive approach, and not thinking that absolutely everything is going to be solved with one of the pillars. You need to think about the whole model of community-based intervention. So let me ask you, do you have questions? comments, experiences. I know it's late in the day, and we've been talking a lot, but I'm sure you have thoughts about what we've talked about. Yes?
When you were talking about people in chronic pain, I guess this would be for people that run inpatient programs. If they have arthritis or need some type of surgery, how do you guys deal with that?
She's asking you. Because arthritis, being the person I am, I know what that means, is something that you can't sort of just will yourself away. So you have to figure out what are we going to do with and for our clients to meet their needs, or not abusing, but still not being in chronic pain and in chronic sickness. So let me ask you, what do you do? Yes?
I don't have any experience in my current place of employment, but before I came to Creek Nation, I worked up in Muskogee. I assisted with an adult drug court program, and the head counselor there, there was never any compromise. If someone came into drug court and they were prescribed a medication that was considered something that they could use or so-called get high on,
Yeah.
he would call the physician and demand that they give them something else. I mean, there was no compromise to that. And if the doctor wouldn't do it, the person wasn't allowed to stay in drug court, which meant jail.
See, I think that's just me.
Oh, I agree.
So you think it's me?
Well, I think you're.
Now, Michael, you are from the medical profession more than I am. So
I thought I understood you to say, I couldn't hear from way up here. Was it an individual that had rheumatoid arthritis? Or did I miss?
I don't remember what their affliction was.
I said anybody with arthritis or needing joint replacements or in their own medicine. Okay, I know a lot of places that we refer our clients to, they don't allow them to be on any new alternate drugs. And so I was like, this was a question to anybody that's in here that runs an inpatient, how do you deal with that?
So the person is in treatment for substance abuse,
Or, alcohol abuse?
alcohol or drug abuse, and they are being sent to, they have a legitimate chronic pain issue, and the treatment facilities will not allow that person to be on a narcotic if they're going to be in treatment.
Yeah, so how do they deal with it?
I will tell you that that is not unique to Oklahoma,
No.
unfortunately. Unfortunately, because the reality is, and this is where it takes some very, very close partnerships. It's extremely difficult in early stages of treatment, where you don't have any length of sobriety or true recovery that's taken place yet, because they're still in that stage of discovery about do I or don't I have a problem. And so that makes it even more challenging. But I think it's important for us, and this is where I think the real issue lies with some of these pillars that Ant's discussed. You know, the education around prescribing. You know, there are some potential non-narcotic pain meds, we probably underestimate some of the anti-inflammatories. But trust me, if you just had, and my wife just had, hip replacement, well, you know, they're not going to let you lie there in bed and give you a Tylenol and say, hey, go home and get better. But the important piece is when we think about integrated approaches to care, we have an educated physician and prescriber who is aware, one, that I've got a person who's already struggling with dependency, but has legitimate pain. And we really try to hook people up with sponsors and people in recovery who understand pain. You know, it used to be when I went to meetings, if you were on medication, they'd tell you in a hurry, you don't belong here. That's not the case anymore. And that was medication if you were depressed. That was somehow violating the fact that you're, quote, in recovery. Well, I went home one day and asked my, at the time, 9-year-old daughter, if a person is depressed and becomes suicidal and they have a substance abuse problem, which one do you treat first? And she said, well, Dad, come on. If you're going to take their life, that's what you address. And if that requires medication, and it's a challenge then. Which came first? Was it because I'm using that I got depressed? Or was I depressed and started using to self-medicate? So you have all of those issues. That's why I'm telling you, treatment of the future is really, if we're going to have effective outcomes, an integrated healthcare system. You need educated primary care docs. Now, unfortunately, and we'll talk about this in a minute, because SAMHSA is doing some things to help physicians understand better how to address chronic pain. And there are some medications that can be used. A lot of medications are buprenorphine has been used.
Methadone has been used.
Methadone has been used but it's not just dosing medicine.
No.
It's in conjunction with treatment and ongoing involvement in recovery.
I think you ought to be aware too that they're going to treatment, and we got some addicts in that treatment along with this person that's hurt going to say, come on here, give me your meds.
Oh, yeah.
You know, so you got to watch out for that, and most treatment centers won't allow you to
Listen, I understand. I ran a detox and inpatient treatment program. I actually developed the intense outpatient treatment model that's still being used in the state of Louisiana. I understand about maintaining the integrity of treatment. But, it's never to the point where a person must stop. And so it's that fine line. It's very complicated. It's not easy. But it takes all of us coming together to manage those more difficult cases.
And I want to say also, have you seen the play Bill W. and Dr. Bob? It's a very, very good play. And it's about the foundation and the founders of AA. They never said, and this is very important, if you go to the big book, it doesn't say that you are not to use medication for medical issues. And how we got to where we were for years and years and years, I don't quite understand. But I understand what you're saying also, because you're trying to create a healthy recovery community. And the balance between that and the fact that Bill W. didn't say that you shouldn't be treated for your medical issues.
Isn't that where we need
You know, the reality is, my experience of working in the addiction world is that, and I'm grateful for what I see there, is we've always been inclusive. It didn't matter what was going on with you. We were going to open the door and attempt to give you the very best we had to offer. Where in some instances, people, and I think that's the way we're supposed to be. I don't think we're supposed to say, well, you got it. And when I ran the detox and inpatient, I used to have this discussion with my nurses all the time. They'd say, well, you know, these people are too sick to be here. I said, well, where are they going to be? Where are they going to be? I mean, we're the last stop on the block. Where are they going to be? So it becomes extremely challenging. And when you live in an environment and in a community where this prescription drug abuse is, just look at the data that we looked at. You're going to be facing it every day. And to sort through, is that pain real? Or is it now psychological dependency coupled with tolerance? And then how do we titrate you to a place where we can actually create a safe treatment environment? I understand the challenge and don't believe that we have all the answers, but I do know that it takes our primary care docs and chronic pain management docs and our addiction treatment world professionals coming together to have these discussions, to do what's best for the people coming out of this.
And it's, from my clinical experience also, is that it's very tough to work with a person who's very addicted to pain medication. And when I'm saying that, I'm not sort of thinking, oh, just taper them off. I once withdrew a woman, petite little thing, with very serious headaches. And my colleagues at the University of Bergen said to me, she is going to be so much worse. And what happened when we withdrew her was, of course, the headache were 10 times worse before they tapered off. So you have a medical issue at hand that needed very careful supervision for us to get her down to a level where we could get her over on something else. So it's a very challenging thing, and we just need to realize that this requires a very comprehensive team to do it. So we're not mean. We understand what it means to have rheumatoid arthritis, whatever it is we are suffering from. Yeah.
And it also touches on the need for medically assisted treatment. And I think, Ann, you're planning on having some discussion about that, right?
Mm-hmm. Yep. Any more questions about this? Okay. We have started this discussion already, because this is really what we have been worried about. What are we going to do with our clients? And how are we going to deal with the fact that our clients, with or without a stable recovery, really want to make sure they can get out on the other side healthy? So I think there are different groups of clients here. I remember very well that the women I treated in my treatment ward had suppressed so much pain for so long with whatever they had been using that we had to really prepare for a lot of emergency medical situations. So a lot of the pain that we have is a result of accidents, falls. Women, and this is important, a lot of women have pain based on previous abuse history. And so we can't say that there is an objective place in the body that has pain, but there is pain. And we can't overlook this because if we do, she's not going to be able to recover. And of course, with falls, we have surgeries, and then you have the long-term excessive use. So some of the pain that we are dealing with is not just what happens in the medical world, but what is also happening as a result of substance abuse. And we've talked about the vulnerability. Who is vulnerable? And people who have had a pain condition to start with are vulnerable for having that kind of issue again, and going over to other substances if they don't get pain relief. And here is professionals in recovery. And we need to think about, and I'm sure you've been faced with this many, many times, that we're working alongside with people in recovery. And we need to respect that, and we need to also be aware of that something may lead into relapse. And I have several experiences with that. What I also think is very important, we've talked a little bit about this before. Stigma is really hindering us a little bit in having an open, frank discussion about prescription drug abuse. Because it is shameful. Because our clients have heard time and time again, you should just get over it. Just do quit. And we know this is not something that you really can do on your own in many cases. That doesn't mean people can't, but with prescription drug abuse, that can be really a medical challenge. The cross-tolerance here is very important to remember, and I always used to say to my clients when they went to the dentist, you need to tell them, even though it may not be something you love to talk about, that you have had a drug and alcohol problem. Because the dentist isn't going to be able to find the level of pain medication that you need if you don't tell them. Dentistry is a profession that more and more are very necessary for our comprehensive team. Because they're the ones very often that see things the first time and do not know how to handle it. And one thing that I also think we need to really very much respect, and that is that if you are in recovery, a lot of people are educated enough to know that they need to discuss with their physician that I don't want any of this. You have to find something else but an addictive drug. And I think that goes for other people than people in recovery. If I have a back issue, which I often have, and they start telling me that we're going to give you Valium, I will say, no, I don't want Valium. Tell me something else that is more constructive and is not addictive. And I think we need to train our clients in being not ashamed to talk about this. Why would we be ashamed of talking about our diabetes? We wouldn't. This is our clients' similar experience. They need to think about their chronic disease as something that they need to take seriously. And my providers need to do this. So we talked already about what do we do with a person who has an addiction and has a chronic pain condition. And again, we heard examples, people in drug courts would say, you need to get off this, or you can't be in this drug court. Or I will call your physician and you need to get something that is an alternative. And that can be very many different things. And the other thing is, looking at it from the wellness court perspective, what is it that is important to do if you have rheumatoid arthritis, if you have osteoarthritis, if you have a chronic pain condition? There are a lot of things that have to do with diet, with exercise, with rest, sleep hygiene. All those things need to go into this, not just, I'm not going to give it to you. This is what we're going to do. But it needs to look at the whole person and figure out what is it going to take for this person to be able to be pain-free without being on very high doses of painkillers. As professionals, we also need to make sure that there are some medications we can't say you're not getting for. Tomorrow you're free. Why is that very dangerous? It is dangerous because the craving can go up so badly. The client can go into seizures. The client can go into DTs if it's the specific kind of drug that can lead to that. So oftentimes we need to make sure that a medical detox is taking place, that we have someone who monitors and tapers off medication. And the guy I told you about in the beginning, who was on 800 milligrams of Valium, how he managed to get this, don't even ask me. It took us 2 months to get him down to a level that you could take him off. 2 months. And what happened with benzodiazepines? When you are without benzos, anybody knows what happened when you're down to 0? People stop sleeping. So this man could not sleep for 2 weeks. And this man had also psychotic breakthroughs for 4 months afterwards. So it was a very complicated situation, but we got him through and he stayed sober. Another group we really need to look at for medical detox is our older clients. Why is that? I don't know about you. I didn't used to be on any medication when I was a little younger, but now there are things I need to make sure I do so I don't have a problem with whatever I struggle with. Our older clients, more and more, will be on medications that not only is very bad in combination with opiates, but bad in combination with alcohol, with sleep. And oftentimes, these clients, our older clients, need medical detox. And if they, by any chance, are on barbiturates, then there is no choice. We can't socially detox them. Okay. So, what I am really recommending when it comes to treatment of chronic pain is a holistic approach that includes a lot of other things than just medication. And a lot of times the client needs to work in collaboration with a therapist to set up different ways of doing this. Now, you get in the morning, you do this. You do this then, and have it almost like the person is going to sleep. If you can find a group that is supportive, if there is a recovery coach, if there is an alumnus group, that very often helps. And I think sober community with support for the client to go through all these different challenges day by day. That will also help the client very much. Yes. Yeah, well, just flash up the contact information. So let me go down. Again, I will be out tomorrow at the booth, and you can contact me if you want to have more information about this, and I will also have some business cards for you. So with that, we're going to go to yours. Let me see here. Hang on. Let me go. Oh yes, no. We've got to go up here and from the current slide. Yes.
Okay, I'm going to just build on some of the discussion that Ann had about the pillars, and I want you to see some of the work that SAMHSA is involved in. It might be of interest to you and supportive of some of the work that you're now doing. There are some common themes of current programs as defined by ONDCP, and I wanted you to quickly see there. You've got prevention and early intervention, you got prescriber and patient education, you've got enhanced treatment access and quality, you got overdose prevention and rapid intervention, and appropriate regulations. So I wanted to very quickly talk about some of the work that SAMHSA is doing in these areas. But in particular, I wanted you to be aware of again, reiterating what Ann's already talked about with screening, brief intervention, and referral to treatment. And we're looking at doing that in emergency rooms and other primary care settings so that we begin to identify populations with problems with prescription drug abuse. These are some results of screening and brief intervention. When you look at substance use at intake and 6 months out, you have 177% change in the reduction of use. And then when you look at employment, you've got a 9%, 10% increase. We're not talking treatment. We're talking screening, brief intervention, and referral to treatment. And these are the kind of impacts. In housing, you've got almost a 9% increase. Arrest, you've got a decrease of about 15.7% in re-arrest rates. And then in social connectedness, also improvement. Now, in prescriber and patient education, we were just talking about this. SAMHSA supports live and online CME courses on prescription opioids for chronic pain. And to date, it's a full-day live course. It's been offered to about 54 sites in 31 states. So when you talk about prescriber and patient education, here's an opportunity. In addition to that, you have online CME courses that are offered at no charge. Now, again, you got to get physicians to engage, but it's an opportunity for you to help them to better understand, and then hopefully we'll begin to change this dilemma that is in existence in Oklahoma right now. Here is prescriber and patient education again. We have a physician clinical support system for opioids. There's the link to that. SAMHSA has published all kinds of information, some of which Ann has referred to. It's on our website at samhsa.gov. We have treatment improvement protocols. I'm telling you, there is a wealth of information there. And I will confess, when I was at the state level, or the provider level, sometimes I didn't feel like I had time to go there. I promise you, it will provide you a wealth of information. And questions that you didn't even know you had can be answered there. There is also the fact that SAMHSA is in the developmental stages of an opioid brief guide for primary care physicians on how to use the FDA-approved medications to treat opioid addiction in the medical office. That's buprenorphine. Here's some the SAMHSA resources: prevention, training, technical assistance. This is a collaborative for the application of prevention and technologies. This is the organization that I was telling you about that provides technical assistance in the arena of prevention. And in particular, they have resources on non-medical use of prescription drugs, risk and protective factors tied to that. And then the infamous American Indian and Alaskan Native Addiction Technology Transfer Center, which Ann represents. A huge asset. These are some other SAMHSA resources. I'm sure that Dawn is going to make this PowerPoint presentation available to you, so you'll have all of these links. But it's everything from our Tribal Training and Technical Assistance Center to Suicide Prevention Resource Center, Child Traumatic Stress Network, Disaster Technical Assistance. It's all there. I wanted to talk briefly about the SAMHSA overdose kit. Have you all heard about it? Seen it? Well, it's a very, very simple kit that SAMHSA created, and it has several different audiences that they target. You have paramedics, EMS, first responders, physicians, and other opioid prescribers, patients who are prescribed opioids for pain. They can get this kit. Overdose survivors and their family members can have the kit. And it's got a section in there on how to use the kit and what to be aware of. This is what it looks like. The price is right. It's free. It's free. All you have to go to is our website and you can download it free. There's been some discussion, and this is all around the idea that we have people dying. What was it, 38,000 plus? And those are preventable deaths. If, in fact, we begin educating people in the use of naloxone. The importance of overdose prevention as it relates to Oklahoma, pretty obvious. Drug overdose is now the leading cause of injury, death in the U.S. Opioid analgesics account for 80% of those deaths. Overdose rates have increased fivefold since 1990. Oklahoma ranks 5. 4 out of the 5 unintentional poisoning deaths involved at least one script drug, 90% related to painkillers. Oklahoma ranks in the top 5 per capita distribution of opioids, and we looked at that together. Really, I think that the issue here is that it requires, as Ann has indicated, a multifaceted approach to be able to really address prescription drug use. It requires appropriate oversight. SAMHSA has provided technical assistance to and financial support to the Federation of State Medical Boards to help them look at, and we actually adopted in January of 2013 a model policy to address treatment of opioid addiction in the medical office. another opioid analgesic in the treatment of chronic pain. That was in 2013. Is that the one that you, that's not the book that you brought?
No.
The tip that you brought?
No.
SAMHSA is also supporting training courses to be offered through the Federation of State Medical Boards. State prescription drug monitoring programs, we've talked some about those, but SAMHSA has been very instrumental in supporting not only the monitoring programs, but looking at ways of integrating those with existing electronic health records. These are some strategies among tribal nations that we've talked some about. The Drug Enforcement Agency, National Drug Take Back, and you have in every sheriff's department the drop box in the state of Oklahoma. That's awesome.
That's
Yeah.
fantastic.
The Office of National Drug Control Policy and the Bureau of Justice Assistance does state to state and state to tribe prescription drug monitoring linkages and interoperability. It's great if you have a prescription monitoring program, but if you can't link to it as a tribe, what good is it? So some of those opportunities. And I wanted to mention the Alliance of States with Prescription Drug Monitoring Programs and Brandeis University, because that center of excellence and IHS is creating some of that interoperability. So I don't know if that's happening here in the state, but hopefully if not, you can take advantage of some of that technical assistance. This is a National Indian Health Bureau and some of the evidence-based strategies that they're employing.
It's the National Indian Health Boards.
Yes. And this is the Parent 360 Script Action Toolkit. Have you, any of you used it? Have you used it? The 11-minute video. Anybody else in here used it? It's a great little toolkit. Again, Price is Right. Media campaign aimed at combating substance abuse and prescription drug abuse. And this is really on the prevention side, but Above the Influence still is one of the leading campaigns in the country. Additional resources, so I think I mentioned one of these before, but I'll mention it again. It's the American Indian and Alaskan Native, ATTC. They have all the webinars that Ann shared with you.
And we post them on our website, but also on YouTube. So you can download it very many places.
Okay? In summary, we didn't actually look that closely at each other's presentation, but I think at the end of the day, it's be knowledgeable about prescription drug use and abuse and the danger that it presents to your community. Again, include tribal leadership. I did want to. Are you?
Nope, no. I have nothing more to say.
I did want to touch on the Tribal Action Plan, which is a technical assistance that you can request from SAMHSA. Many states are taking advantage of this, and it's a great opportunity. So if you have an interest, I'm going to just